Good morning, everyone, for our clinical meeting. It's a little lean period of the year, but glad to see all those who have come. Want to welcome geriatrics department also today morning. So I think our opening batsman is from geriatrics. We'll welcome Dr. Sara. Will be presenting from geriatrics. The title is Infirmitas Knox. Good.
Good morning, everyone. I'm presenting on behalf of the Department of Geriatrics. So I'll be presenting two patients. The first was an 86-year-old man who presented with slurring of speech, which was acute in onset and progressive over 20 days. He also had dysphagia to liquids followed by solids and decreased oral intake for 15 days. He had pooling of saliva and inability to chew. However, he was able to respond and comprehend well. He had initially presented to geriatrics where he'd gone to ENT and then neurology, where he was diagnosed to have a CVA. He presented after 1 week with left eye ptosis with doubtful history of fatigability. There was no history of any limb weakness, deviation of angle of mouth or tongue, no change in voice, no dinophagia. Bowel and bladder were continent. There's no history of any difficulty in breathing, no double vision. He did not have fever, headache, vomiting, or altered sense organ. He was previously diagnosed to have pernicious anemia and primary open-angle glaucoma. And his regular medications, he was on aspirin, statin, vitamin B12, and vitamin D. On examination, he was conscious, alert, oriented to time, place, and person. Vital signs were stable, TVP was not elevated. The cardiovascular, respiratory, and abdomen examination were normal. On CNS examination, the second renal nerve was normal. He was found to have left eye ptosis, and gag was noted to be weak. Motor examination was normal, GPS was intact, rhombox was negative. The gait was normal, cerebellar system was normal, and sensory system was also normal. He was noted to have some fatigable weakness theater, and nasal twang was present to the voice. The patient's condition progressively worsened, and he was admitted for evaluation. An NG tube was inserted for feeds. The differentials were considered a posterior circulation stroke, a pontine lesion, bulbar onset MND, and myasthenia gravis. Investigations were grossly normal. He had B12 deficiency, and TSH was mildly elevated. Flexible laryngoscopy was done, which was normal. MRI brain was done, which did not show any acute infarct or intracranial hemorrhage. However, there was a left frontocortical subacute infarct and few chronic lacunar infarcts in the brainstem and left cerebellar hemisphere. EMG we did showed the repetitive nerve stimulation study showed postsynaptic neuromuscular dysfunction, and acetylcholine receptor antibody was elevated. After that, we did a CT to look for thymoma, which was not present. He was diagnosed with late onset myasthenia gravis with predominantly bulbar symptoms, thymoma negative with anti-acetylcholine receptor positive and RNS positive, with chronic infarct in the brainstem and left cerebellar hemisphere. The second patient was a 70-year-old shopkeeper from Tamil Nadu who presented with difficulty in swallowing his speech for 2 months. He said that following this, he also developed weakness of the right upper and lower limbs. The CT brain done at that time elsewhere showed a left subacute lacunar infarct. He was diagnosed with CVA and was started on single antiplatelet and atorvastatin. Currently, he presented with acute worsening over 2 days. Initially, he was able to take liquid and semi-solids, but now he was unable to take anything orally. The repeat CT in June 24, which also was done outside, showed few chronic lacunar infarcts seen in bilateral gangliocapsular regions. He then, his first presentation in CMC was the ED, where an NG was inserted and he was referred to OPD. On probing, he gave history of occasional double vision with doubtful history of drooping of eyelids and nocturnal worsening of ptosis. Symptoms, he said, were worse in the evening. He also had right limbs fatigable weakness with no sensory loss, bowel and bladder were continent. He did not have any known comorbidities. He had loss of weight of 10 kg in 2 months. He was unable to take anything orally. For the past 2 months, he was on atorvastatin, clopidogrel, Livogen, folic acid, and cognizant. On examination, he was alert, oriented to time, place, and person. Vital signs were stable. The cardiovascular, respiratory, and abdomen examination also normal. Cranial nerve examination showed deviation of angle of mouth to the right side. There was no gaze palsy, mild slurring of speech was present. Gag was absent on the left. Motor examination and sensory were normal. The cerebellar signs were also negative. And rhombox was negative. He did not have any fasciculations. The differentials again considered were CVA, myasthenia, MND, arrested GVS, any structural brainstem lesions, and pontine lesions. Investigations were again grossly normal. MRI was not able to be done as he could not lie down flat due to aspiration of the cold saliva. CT brain showed few chronic lacunar infarcts in the bilateral gangliocapsular regions and age-related atrophic changes. NPL-scopy was done. He was not able to take anything orally on swallowing assessment, and the query bilateral abductor paresis was also documented. For him also, the acetylcholine receptor antibody was found to be positive, and repetitive nerve stimulation was significant of postsynaptic NMJ transmission defect. For him also, the CT was done for further evaluation, did not show any timing. He was diagnosed with bulbar onset myasthenia gravis with acetylcholine receptor antibody positive, RNS positive, and chronic lacunar infarcts in bilateral gangliocapsular regions. The first patient was treated with pyridostigmine, methylpyrazone, rituximab, and after this his symptoms improved and he started on oral feeds which he tolerated well, after which the NG tube could be removed. The second patient was started on pyridostigmine with which symptoms improved, and after that he did not come for follow-up. So as we know, myasthenia is an antibody-mediated autoimmune disorder affecting the postsynaptic neuromuscular junction. It's largely treatable but can cause significant mortality and morbidity, which can be prevented with timely diagnosis and appropriate treatment. It's important to remember that it has a bimodal distribution. And in older age group, 60 to 89 years, it's more common in men. It can present with a spectrum from purely ocular to severe weakness of the limbs and bulbar and respiratory muscles. So in these two cases, we presented to highlight the acute subacute onset of illness with the mainly bulbar symptoms. Ocular symptoms were minimal in both of these patients. So in the acute medical setting, a range of acute onset neurological symptoms are frequently initially attributed to stroke in older adults due to the coexistence of vascular risk factors. So it's important to have an awareness of the diversity of conditions that can cause this apparently acute or subacute neurological dysfunction. So often when these patients are misdiagnosed with stroke and started on various treatments, including aggressive therapy such as intravenous thrombolysis, this can lead to serious adverse outcomes when it is not indicated. It's important to take a careful neurological history and examination. So patients are usually diagnosed when suspected in patients with a history of fatigable muscle weakness, including those with isolated ptosis or diplopia. Some tests which were suggested are the IcePack test, hydrophonium test, and serological diagnosis is done with the acetylcholine receptor antibody, mask antibody, and LRT4 antibody. It can be seronegative in 6%. And repetitive nerve stimulation is positive in 75 to 80%. And single fiber EMG is the most sensitive diagnostic test. And MRI, CT, and LP are done to look for other associated conditions. These are some of the differentials for various presentations of myasthenia gravis. For ocular, brainstem and cranial nerve lesions, thyroid ophthalmopathy. For bulbar symptoms, brainstem and multiple cranial nerve lesions, MND. For patients presenting with limb weakness, also we can suspect MND, CIDP, and other motor neuropathies. Isolated neck, isolated respiratory, also MND is suspicion, as well as for distal limb weakness. And we manage them with pyridostigmine, chronic immunotherapies, immunomodulating treatments, and thymectomy can be considered in certain patients. It's also important to remember the drugs that can unmask or worsen myasthenia gravis. One of these medications is statins. However, statins are still indicated in patients who require it for cardiovascular or other reasons. The take-home message is that it's important to consider the possibility of myasthenia in elderly patients as well. And concomitant illness and disabilities, including vascular conditions, can be misleading, especially in the elderly. It can be a stroke mimic with acute dysarthria and dysphagia. And so you should look for fatigability and diurnal variation. And prompt diagnosis and management can reduce the morbidity and mortality in the patient. Thank you.
Thank you, Sara, for this wonderful case. At this age, suspecting myasthenia is very important. What would have been a clinical suspicion on these patients where typically we are thinking of stroke would help differentiate stroke from myasthenia?
Fatigability of the weakness.
So did they have?
Initially, they did not have. One patient after admission in ward, we had noticed that symptoms.
Thank you. So that helps clinically so that we go on for the definitive diagnosis. Any questions? Yes, Mr.
This myasthenia gravis, Sometimes external ocular movements are also affected. Then they have a complex ophthalmoplegia, which doesn't fit in with any cranial nerve distribution. And another disease it presents with difficulty in swallowing cancer that we've had 2-3 cases in the past is dermatomyositis or polymyositis. We've had patients presenting with initial difficulty in swallowing, severe difficulty. That's a well-known presentation. So basically, there's no motor neuron and pure motor, no sensor, right? The first patient had,
Yes.
had a little local fatigability. The second patient actually did not have. They just said it kind of was there from small bleeding. There's no real value disease. But it was going on multiple hospitals. They kept doing CT scans.
So what was the next investigation? Was it EMG or did we go for the antibodies?
We did the assigned the second.
Okay.
But EMG was first. EMG is yeah.
Right. Okay.
EMG was first. We sent the test. What with the EMG? I showed a.
Any other questions?